Hello, I'm Matthew Balti with the Acoustic Neuroma Association. I'd like to welcome everyone to the 2024 ANAwareness Week presentation of an overview of AN surgical options with Dr. Rick Friedman and Dr. Marc Schwartz with UC San Diego Health. You can stay up to date with ANAwareness Week and everything the ANA has to offer at anausa.org. We also hope you'll make plans to attend World Vestibular Schwannoma Awareness Day on June 22nd. You can find more information about that on our website and social media pages, Facebook, LinkedIn, Instagram, and Twitter. Our website is a great resource for so many topics you may have an interest in. There's a search function so patients can find just what they're looking for. The ANA is here to help, so please access those opportunities. So Dr. Friedman and Dr. Schwartz, if you'd like to turn on your camera, share your screen, and introduce yourself, we can get started.
Hi, I'm Rick Friedman. I am a neurotologist at UC San Diego Health and co-director of the UC San Diego Acoustic Neuroma program.
And I'm Dr. Marc Schwartz. I'm the neurosurgeon at UCSD, working together with Dr. Friedman. Our practice together is nearly all acoustic neuromas.
Now I will share my screen and we will okay. So this morning we're going to talk a little bit about contemporary management of acoustic neuroma. We are a full service center, and as Dr. Schwartz said, I would say 99% of what we do surgically is acoustic neuroma. So we're a very focused center. We do offer all forms of care, which include watch and wait, radiosurgery, and surgery. But the topic we were given today is surgical approaches. So I'm going to talk about surgical approaches and skip past radiation. So tumors of the CPA. The CPA is the cerebellopontine angle. It's the area where these acoustic neuromas reside. When they're big, you can see them sitting next to the brainstem, and that's an area called the cerebellopontine angle. We're going to limit our conversation today to schwannoma. The etiology, how do acoustic neuromas or vestibular schwannomas occur? Patients always ask that question, and the answer is we still don't fully understand. It's likely a local genetic event with a mutation in the NF2 gene. So it's called the NF2 gene, even when it's not in a case of NF2. So even if it's a unilateral acoustic neuroma. The only thing we know is that low-dose radiation can contribute to the formation of these tumors. But other than that, the environmental influences are not well understood. The most common presenting symptom is hearing loss, tinnitus. Some people have dizziness, and then less often, but certainly we see this, headaches and tingling of the face. Management considerations are preservation of life, preservation of function, facial motion, hearing, and balance when possible. Balance obviously is difficult to preserve because it's a balanced nerve tumor. But preservation of facial function and hearing are what we focus our attention at UCSD on. Management options include observation, surgery, and radiation. And as I said, today I'm going to be talking about surgical approaches. Decision-making factors for care include the age and life expectancy versus the average growth rate of a tumor, the general health of the individual, the size of the tumor, the symptoms and signs. And even though I saw this coffee mug that said, please don't confuse my MD for a Google MD. Patients are so much more well-educated these days and with MRI, we're finding them so much sooner that it really is a cooperative agreement between the treating surgeon and the patient. There are lots of options frequently. Obviously, with observation, the risk of growth increases treatment risks. I'm not going to talk too much about hearing. I'm going to go straight to approaches. So I'm skipping through some slides here. Okay. The surgical options. So in my opinion, a center of excellence for acoustic neuroma care should be one that provides everything. Like I said, observation, radiation, and all three surgical approaches, because really the cutting edge of acoustic neuroma care when the tumors are small and it's possible is to try to save the hearing. So TLC stands for translab craniotomy. So the translab approach, which I'll show you, is indicated for patients who have non-serviceable hearing in their ears. And that's typically a word recognition score of less than 50% and a speech reception threshold of less than 50 decibels, and or large tumors where hearing preservation is unlikely. And I would say that tumors over 2 centimeters, but really over 2.5 centimeters, the likelihood of saving hearing surgically or with radiation is very low. So this is a sort of tumor we're talking about with regard to the translab approach. This is a large tumor, and hearing preservation is not possible. And the primary goal here is to protect the brain and the facial nerve. And the translabyrinthine approach affords us this angle of vision. So rather than, say, the retrosigmoid, which I'll discuss, which involves going through this portion of the brain, we have to retract it. The translab actually allows us to go straight onto the tumor. So we favor this approach for large tumors. It allows us to see the facial nerve where it's normal right away. And it gives us, as I said, this lateral view without brain retraction. This is an illustration, not in the surgical position, but on the right here, you see the inner ear structures, the cochlea and the labyrinth, the balance organ here. The tumor usually resides here in the canal. This approach involves going behind the ear through the mastoid bone, and we remove these balance canals to get to the tumor. So that's why dizziness is often a symptom after surgery. Here are some anatomical slides. This is a right mastoid, and this is with the mastoid opened. And these are the balance canals. This is a human specimen. It's a preserved specimen for dissection and education. So the next step in the surgery is to remove those balance canals. So I'll go back. The balance canals are here. This is the covering of the brain called the dura, but we need a better view, a more complete view, including of the internal auditory canal. So we remove those balance canals, and that affords us a wide open view of the structures of the inner ear. I'm sorry, the structures of the brainstem, including the nerves that we need to protect. These are the lower cranial nerves that are involved in speech and swallowing. These are the hearing and facial nerves, and this is the trigeminal nerve, the nerve that's important for sensation on the face. So once we've exposed the tumor, we open the dura and we remove the tumor. Total tumor removal, no, this says greater than 5,000 cases. We together, Dr. Schwartz and I, have probably done a little over 2,000 cases together, maybe a little more than that. We've shifted away from total tumor removal when not possible. In other words, when the tumor is so stuck to the facial nerve that we worry about injuring it. So we will do a near total, which Dr. Schwartz can talk about. Our recurrence rates are low. Facial nerve functional preservation is great when we look at all comers. I would say we have at least a 90 to 95% chance of normal facial nerve function. And then there are a percentage of patients, depending upon the size of the tumor and the stickiness, that have temporary facial weakness, but most often it recovers. Not always, but most often. Yeah, with our latest approach, as I was describing with near totals, we've got about a 97% rate of grade 1 or 2 function, which is really an excellent outcome. The middle fossa craniotomy is an approach that we use for small tumors in patients who have good hearing when we want to preserve their hearing. The indications are tumors up to about a centimeter, mostly confined to the internal auditory canal, tumors that abut the base of the cochlea, and patients with good hearing. So this would be an ideal tumor in a case for a middle fossa. You can see this tumor here on the patient's right. This is the cochlea here. These are the balance canals. And here is this little tumor. These tumors, this is actually a human section, a pathological section, showing the tumor going right up to the base of the cochlea. And this approach affords us the ability to get to that location without sacrificing hearing during the approach. So it involves a craniotomy on the side of the head above the ear. And after the brain is relaxed, we place a retractor in to afford us a view of the floor of the middle fossa. And then we remove this bone surrounding the tumor. We use this approach very often in cases of small tumors with NF2, because as you may or may not know, but if you have tumors on both sides, these patients are at risk for losing hearing in both ears. So we often take a proactive management strategy for patients with NF2 and try to at least save the hearing during the first operation. This is just showing the anatomy with the cochlea over here. This is not the anatomy you would see during surgery. We wouldn't open the cochlea, but this is for educational purposes. Here's the balance canal. Here's the facial nerve, the hearing nerve, and the balance nerves. I think I'm going to defer and let Dr. Schwartz discuss the retrosigmoid approach, because this is more of a traditional neurosurgical approach, even though neurotology is involved. My role in these cases is to open the internal auditory canal and remove the tumor from the canal. But I will have Dr. Schwartz discuss the approach. Marc?
That's the picture you have. So the retrosigmoid approach is another approach where we have the opportunity to try to save hearing. It is an approach next to the cerebellum, behind the ear, further back than the translabyrinthine. So with the translabyrinthine, we go through the mastoid. There's a big vein called the sigmoid sinus, which we try to preserve, and then we go behind that to go for a retrosigmoid approach. That's why it's called retrosigmoid. Maybe we don't actively retract the cerebellum very much at all, but it is an approach that goes next to the brain to get to the tumor, and we work behind the balance canals to get there. And as you can see, this is a picture of the nerves going into the bone, and the bone gets drilled up to the balance canals to get to the part of the tumor in the canal. It's better for obviously only patients who have still serviceable hearing. So it is possible to use this for any tumor, and even if hearing preservation is not a goal. But in our practice, we favor the translabyrinthine operation whenever we're not trying to save hearing, because we're working around the inner ear structures instead of going through them. We have the opportunity to save hearing. Whereas the middle fossa is good for the tumors mostly in the canal, because it gives a very good view in the canal and a little bit outside the canal. The retrosigmoid approach gives a good view of the tumors that are more next to the brain as opposed to in the canal, and they can be a bit larger. We give a good view working next to the brain, and a good view into the canal, but not quite as good a view up to the very end of the canal. So it's a matter of looking at the pictures the MRI pictures to determine which is the better approach. We talk about hearing preservation approaches, and obviously it's never a guarantee to save hearing. The hearing nerve is very sensitive, and we never know exactly what the relationship between the tumor and the nerves are going to be, and we are dependent a bit, especially as tumors get a bit bigger. We're dependent on finding things relatively favorable to really have a chance to save hearing. If we get in and find that things are just anatomically not favorable, the chances get very low. And as tumors get larger and larger, that chance of saving hearing is less. So for small tumors, the odds are potentially quite good. But as tumors get larger and larger, the odds go down from there. To the point when tumors get to be past, let's say, every case is a little different based upon exactly the configuration of the tumor, and also depending on exactly how good or how bad the hearing is. But let's say for somebody with very good hearing, as a tumor gets to be above, on average, about 2.5 centimeters, I mean, those odds are so low that I think it's time at that point to optimize outcomes other than hearing. The odds of success of saving hearing are very low.
So I think that covers the approaches. I'm wondering if we can now open it up for questions, and then Dr. Schwartz, we'll take over.
I mean, yeah. So I'm just speaking about the surgery and the approaches. I mean, this is not so much approach specific, but I mentioned that the odds of saving hearing go down as tumor size gets larger, and as frankly as hearing gets worse. So when we're talking about hearing, we have to consider the other goals of surgery, including getting the whole tumor out, obviously the safety of the operation, and what people are most concerned about is always facial nerve function. And we have to balance the hearing preservation possibility against those. To the point that in many occasions, even when somebody has good hearing, but especially a larger tumor, we say it's not even worth trying to save hearing because we want to optimize everything else. And in those situations, we at least do a translating surgery. The facial nerve is the main anatomic structure that we're really focused on taking these tumors out. And the facial nerve is another small, delicate structure. So it's like a piece of cooked linguine, but it's not physiologically super sensitive in the same way that the hearing nerve is. So it tolerates what we do in surgery. So we know that there's risk. We know we can never eliminate the risk entirely, but we know that if we are doing a good job, that we have in general very good outcomes. And we're focused on what the proper way of approaching the relationship between the tumor and the facial nerve is. So if we can get a whole tumor out, I mean, we generally always go in with the goal of getting the whole tumor out, and that's often or usually possible. But it's also common to have the tumor very stuck to the facial nerve. In a situation where we've gotten most of the tumor out and have the last bit of tumor very stuck, we certainly would rather leave a little bit of tumor on the facial nerve and have a functioning facial nerve with a little white dot on the MRI, as opposed to having a poorly functioning facial nerve and an MRI that looks perfect. That's not a good trade-off. But I have to also say that we have to respect the facial nerve, but we also have to respect the tumor. So really, it's of significant benefit to have as little tumor as possible. If we leave too much tumor, that's not going to be good for patient outcomes if the tumor is growing back after having already been treated. So I think that's what we wanted to come and say, so we can answer. Now we can open it up to the questions.
Great. Thank you so much, Dr. Schwartz and Dr. Friedman. We do have some questions to get to. Somebody writes in, is there a general age that is thought of that might be too old to have surgery?
Well, obviously patient age plays a role in our decision-making about what to do. In thinking about doing surgery, we are, we're going to be less aggressive, or we're going to be less thinking about surgery as people get older and older. But there's a lot of factors other than age. So in addition to age, we're also looking at tumor size, tumor growth rate, symptoms. And there are some situations in which older and even elderly people, surgery is a good option, assuming the patient's healthy enough to have surgery. For a large tumor that's growing, my maximum age is 94. And now that's an unusual situation, but I'd say it's not impossible. Even for somebody in their 70s or 80s who's is just very, very dizzy, and has a tumor, especially if the tumor is growing, surgery might be the best option. We're obviously going to not have the same approach to somebody who's 80 years old or 75 years old than we would to somebody who's 20 or 30 or 40 or even 50 years old.
Great. That's some good information to have. You mentioned tumor size being one of those factors. Does tumor size affect how long you might be staying in the hospital post-surgery and how long your recovery might be?
It's an interesting question. So there's sort of two factors that go into that. The first is the overall risks of surgery. Now, in a large volume center doing lots of these, the risks of bad complication are low. But the bigger the tumor is, the higher the risks are. So yes, if there's a problem with surgery, it should be rare, but not impossible. You might need to be in the hospital longer. The other issue is, why do people stay in the hospital after surgery? For a surgery that goes well, the risk of the operation itself is probably only about a day or two of needing to be observed in the hospital. But many patients don't feel well, and especially the main reason for that is dizziness. So when doing surgery, and this is true of any approach, so not just translabyrinthine, but any approach, the tumor grows in the balance nerve. So the balance nerve has got to go with the tumor. There's no way to preserve the balance nerve entirely. And the brain is pretty good at compensating for loss of balance nerve function, but it doesn't do well. It doesn't do well right away. So if you have a sudden change in your balance nerve function, patients can be very dizzy and potentially feel very miserable. And so surgery involves a change in the balance nerve function. So typically cutting the nerve or cutting part of the nerve and having a sudden change in the balance nerve function. Now, there are some patients that come to us that already have their balance nerve is already bad from the tumors. The tumor is taking the balance nerve. And so if the tumor is already taking the balance nerve and we're cutting the nerve that's already not functioning, patients have a pretty easy recovery in terms of that. And so actually, now this is not reliable 100%, and it's just a general statement, but patients with smaller tumors tend to have better functioning balance nerves before surgery. So what we actually see is sometimes people with larger tumors have an easier recovery than patients with smaller tumors, specifically in terms of the balance recovery and having to recover from that right after surgery. So it's not infrequent that we operate on a patient with a big tumor and a small tumor, and the person with a big tumor is out of the hospital faster.
Interesting. Looking at a different symptom here, this patient says that they have frequent headaches. Should this be a factor when deciding on which approach to take for surgery?
So there's different aspects of headaches with acoustic neuromas. So the first thing to understand is that headaches are just headaches in general are very common. For everybody, for all people, headaches are a common symptom. And if you do if you survey the general population of everybody and ask about headaches, it's only 2% of people say they never have a headache. Now, of course, there's variations, and there's some people that have bad migraines and bad other problems that they're very, very headache-prone people with whether or not they have the acoustic neuroma. And so we always have to factor in how what the patient is before bringing to the table, not even considering the acoustic neuroma, just considering them as a person. Now, acoustic neuromas, having an acoustic neuroma, if we survey people with acoustic neuromas versus people without acoustic neuromas, people with acoustic neuromas in general are more prone to headaches than people without acoustic neuromas. That's not to say every patient with acoustic neuroma is having headaches, but just statistically speaking, if you have an acoustic neuroma, you're more likely to have headaches than somebody who doesn't. And that's true if you have a small tumor. So it's not just from pressure of the tumor on the brain, which is frankly pretty rare these days in the United States because we diagnosed them earlier than that. It's probably related mostly to the balance nerve. And so you think about the balance nerve dysfunction making you dizzy or causing balance problems. The balance nerve is also involved with a lot of brainstem reflexes. So there's reflexes that involve the balance nerve and the balance canals having to do with tracking with your eyes, turning your head and having your eyes stay the muscle tension in your neck when you're in different postures. So if your balance nerve is not functioning physiologically 100%, that's not going to say it's necessarily going to be a major problem, but it may be just altering your neck muscle tension a little bit, or making you have to focus a lot more, concentrate a lot more on doing things. And hearing loss may make you have to concentrate more also. And so those factors probably are what, at least indirectly, make people a bit more prone to headaches with acoustic neuromas. Now in terms of treatment, so no matter what you do, if you observe the tumor, if you do radiation, if you do surgery, you're going to, as an acoustic neuroma patient, be on, and this may not be every single patient, be a bit more prone to headaches than somebody who doesn't have an acoustic neuroma. Now, if you go back and look at sort of historically, the retrosigmoid surgery in particular has always been thought to be an operation that causes a lot of headaches. So going back 30, 40, 50 years, patients who had retrosigmoid surgery had a lot of bad headaches afterwards. And what's, and why that is there's a few different theories, and it may be multiple reasons. But and I'm not saying that everybody does it the same way, but centers in which are doing a lot of surgery, I think, understand that and recognize that we have to be careful when we do that operation. And with every treatment, we've got to be careful. We've got to open the muscle carefully. We've got to watch out and make sure we don't hit the occipital nerve. We've got to close everything up very carefully. We've got to be careful when the drilling is done to make sure that we're neat about it and don't have bone dust and material spreading all over the place. And so the experience of people doing a lot of these, I think, has changed so that it's not that same big problem that it used to be. So the headache outcomes when you're careful about doing the surgery. Now, let me take this back a second. I can kind of guarantee you that if you have surgery, you're going to have a lot more headaches a week or a month after surgery than you would after any other treatment. But when you look long term, after a year or two, yes, people with acoustic neuromas tend to be more prone to headaches. But the treatment that you do doesn't affect that very much outcome wise, as long as the treatment is done well.
Great. It's fascinating that you mentioned that. We actually had somebody write in asking if they have more frequent and more intense headaches before surgery, can they expect to have them post-surgery as well? And it sounds like in the near term that can expect to happen, but long term, a lot of times people kind of get through that.
Yeah, I think people in general, we have some people walk out and feel great, but I mean, you can basically expect to feel, the surgery is a real operation. You've got to recover from it. So you can expect that you're going to have to go through a period of not feeling very well for a few days or a few weeks after surgery. But there's the long-term outcomes, how you do for the rest of your life, are not really affected that much, assuming everything goes well with treatment, no matter what the treatment is, from one treatment to the other.
Great. We've got time just for a couple more here, Dr. Schwartz. Someone was writing in asking if you've heard of anyone reporting crawling sensations along their neck and the back of their head post-surgery. They also mentioned that their facial paralysis is showing good recovery.
Okay. Well, in terms of crawling sensations, I assume it's on the same side as surgery. So we worry a lot about the nerves next to the tumor, which are the facial nerve, which everybody knows about, and the trigeminal nerve, which is the nerve for sensation on the face, which can be affected by larger tumors that push on that nerve. When we're doing surgery, there's a few other nerves, let's say on the scalp, and with the approach that we've got to be concerned about in doing operations. And the main one of those comes into play mostly with retrosigmoid, which is the occipital nerve. That's the nerve for sensation over the back of the neck and the scalp, and it comes from the top of the cervical spinal cord and goes up to over the top of the head for sensation. And so in opening up the incision behind the ear, that nerve can be injured. And can cause some symptoms, and that's why it's important to be careful about that and avoid it. It can be injured down at the very bottom of the approach where the nerve is in the muscle. And my experience, at least, is when the nerve is injured down low, it can cause some bad problems and bad pain problems, and it's important not to do that. And it can also be injured at the top of the incision, up above where all the muscles are, just going up to the scalp. Usually that doesn't cause a lot of bad problems, but it can cause funny sensations in the back of the head and back of the neck. And so that may be what that issue is. And then the other issue is facial nerve recovery. The hearing nerve doesn't have really the potential to recover. So if the hearing nerve is injured, it's not going to get better. The facial nerve does have the potential to recover. So there's different degrees of facial nerve injury. And so we always discuss risks of permanent injury, either total injury, which is a low number, or partial injury, which is still a low number. And then the risk of a temporary facial weakness that then gets better, either to normal or to good function. And for a nerve that's stretched or stunned, so that the nerve fibers don't die, it's just stretched or stunned. There's usually a few weeks of recovery, and if even if the nerve is injured to the point that the nerve fibers die, as long as the nerve is in continuity, those nerve fibers will grow back, and it won't ever be a totally normal function, but you can get pretty good recovery, which may take months or even up to a year in that situation.
Great. And time for one more. What are the risk factors for a CSF leak?
What are the risk factors for a CSF leak? So another concern about surgery is risk of spinal fluid leak. And again, no matter what approach is taken, you're going through the temporal bone, and the mastoid, which is the bone on the outside, and the temporal bone, which is a bone that's holding the inner ear structures, the Bowers canals and the cochlea, as well as the middle ear, and there's air spaces in there. So there's air spaces, there's sinus spaces, there's like a honeycomb of air spaces around all those structures that are connected to the middle ear, and then the middle ear is connected to the nose via the eustachian tube. So the eustachian tube connects to equalize the pressure. So when we open up those spaces, there's a natural potential risk for fluid to leak out. And you think about fluid leaking out, there's really two different there's two different reasons for fluid leaking out. The first one is obviously anatomy. So if you leave a hole that's in communication, that's going to be a potential reason for fluid leak out. And the other one is that the fluid's under pressure. So fluid under pressure is trying to escape. And so the higher that pressure is, the higher the risk of a spinal fluid leak. So there's an anatomy reason and there's a pressure reason. And I think we have to think about both of those when we're doing surgery to make the risk of leakage as little as possible. And in terms of anatomy, it means understanding where those holes are and packing them off as good as possible. And we use several different things to pack off those spaces when we can see them. One of which is fat. So we harvest fat from patients' belly to put fat in to fill to sort of pack off those spaces. And another is the other one is that we talk about a lot is bone wax, which is it used to be beeswax, but I think now it's not. Now it's artificial. So we have this wax that we use that's try to explain it. It's softer than candle wax, so you can smush it around and use it to pack off spaces. And so we have to make sure that there's no open space to allow fluid to come out. And then the other one is we've got to manage pressure. And so why might pressure be particularly elevated in one person versus another? One of which we can do something about, which is we've got to be careful when we do the surgery and make sure that there's not a lot of debris and blood that's circulating in the fluid after surgery, because that'll tend to clog up the natural fluid. It'll clog up the ways that fluid naturally flows and elevate pressure. And so everybody has a little bit of elevated pressure after surgery because of that. But we want to make that as minimal as possible. The other one is there's individual difference from one person to another, and we never know exactly what the pressure is going to be Frankly, heavier people tend to have higher pressure than lighter people. And so when we look at a patient and know that maybe if they're a bit heavier, that they're a little bit more likely to leak because of pressure. I don't think that's a huge difference, but that's probably something that we figure. In some cases, we use a drain in the back, so we will put a drain in the lumbar in the spinal canal, like once to drain fluid to the outside, and that sort of relieves the pressure and lets things heal up better also.
Great. Dr. Schwartz, thank you so much for your time. I know Dr. Friedman had to leave a little early, but thank you both so much for your time with the presentation and insight and answering some questions. We're grateful for what you do for acoustic neuroma patients and the way you and UCSD partner with the ANA. So thank you.
Right, thanks a lot.
Awesome.